Uh, Good morning to all. At the outset, I'd like to wish Happy Diwali to all of you. But at first, we are talking about a morbid topic like ALS. But today, we'll be discussing electrodiagnosis of amyotrophic lateral sclerosis. Uh, it's been a disease which has been vogue for a very long period of time. It's been first described by a French physician called as Charcot, who described it in 1869. And what we've learned, what he had described around 13 patients with ALS who came with progressive stiffness, weakness, atrophy, fasciculation, finally death. And he serially followed them up for from 5 to 6 years, and subsequently did post-mortem examinations on them. And exactly he that is recognized that the term has two components. That there is amyotrophy and there is sclerosis. So amyotrophy causing the LMN, and the lateral sclerosis which contributes to the upper motor neuron dysfunction. So the spectrum of motor neuron disease is very wide, and ALS is just one aspect or one disease in a very large spectrum of motor neuron disease, which range from low motor predominant diseases in the form of diseases at the bottom are all the acquired, and the diseases at the top are the inherited ones. So at the left aspect of the table is predominantly LMN dominant, and on the right aspect is all UMN dominant, and various combinations in between, with ALS being the most common phenotype that we see in our clinical practice. So very briefly, just going through the clinical, as generally a middle-aged, late 40s, early 50s, middle-aged gentleman, lady who presents with asymmetric weakness, distal dominant normally, pure motor, progressive, going from one limb to the other, and then generally the average time course is between after 2 to 3 years since the onset of illness, they generally become end stage. Anything less than 6 months we consider as very rapidly progressive. Anything more than 5 years we consider as slowly progressive. So classic ALS is generally divided into the bulbar and the spinal, and they are restricted phenotypes with FTD associated only isolated bulbar, or like I previously mentioned, pure LMN or pure UMN dominant, and very rare phenotypes like isolated cachexia alone as a manifestation of ALS, and diaphragmatic onset ALS where they present to pulmonary medicine and cardiac specialty doctors with orthopnea, and subsequently after negative evaluation being diagnosed to have ALS. So these are the various forms, just as a diagrammatic representation, with the orange color demonstrating the LMN and the blue color demonstrating the upper motor neuron dysfunction. The various colors in the spinal onset showing at what point in time each limb was affected. The UMN dominant ones predominantly showing only upper motor neuron dysfunction with some few islands of LMN only on EMG or certain neurophysiological tests. The pseudopolyneuritic ALS, which presents with bilateral foot drop, and in fact mimicking a polyneuropathy like kind of presentation. So the reason generally ALS is classified based on normally the site of onset and the progression, and we this helps in guiding treatment and prognosis. For example, bulbar and respiratory onset ALS have poor prognosis. They tend to progress faster. Death is earlier. It's important for patients also to understand, and their families. As more and more clinical trials are happening in ALS, it is important to make groups homogeneous so that then only we'll be able to, maybe some subtype will be more responsive to certain kinds of therapy. And classifying them into various subtypes helps in recruitment to clinical trials, though some phenotypes will progress from one type to the other. They don't remain in one phenotype at every point in time. So I like to emphasize this point, the diagnosis of ALS remains clinical, and that there are no definitive diagnostic tests. This is a progressive motor disorder, and the words progressive and motor disorder are the most important words in the diagnosis of ALS. The use of neurophysiology or electrophysiology is only to identify, or predominantly to identify, abnormalities which are not apparent on clinical examination. An evidently wasted limb or evident fasciculation is very evident, or an evident spasticity is very evident. So electrophysiology doesn't add much. But in relatively normal looking limbs, if you're able to demonstrate problems, that is where electrophysiology helps us. And also definitely in helping out differentiating mimics of ALS, which we will come to subsequently. So just coming to nerve conduction studies, predominantly the whole point of doing a motor nerve conduction in particular and sensory nerve conduction is to rule out, exclude other causes of motor neuron disease. So by and large, we in all most of the persons, we consider that snaps are normal in nerve conduction studies in motor neuron disease. Theory literature says that up to 30% of ALS can have sensory abnormalities, but by and large in clinical practice, we consider that snaps are normal. If you have a definite ALS who has snap abnormalities, we must consider the possibility that it could be an additional entrapment or a pre-existing peripheral neuropathy, or it is an atypical motor neuron disease. The conduction abnormalities that we see, the motor conduction abnormality that we see in the ALS depends on where the disease has started. For example, if a patient has predominantly bulbar onset disease, peripheral limb conduction at the early point of the disease may not show any significant abnormalities. So the CMAP gives us a global overview on what is the denervation that's happening and what is the pace of the renervation that is happening. So if they're able to keep pace, the CMAP may not fall at all till the end. So when the CMAP falls, we understand that that is not being able to keep pace. The renervation is not able to keep pace with the denervation. And it is also important to understand that such very low CMAP that we see in as the disease progresses and patients become bedbound, and when you do motor conduction studies on them and they have diffusely low CMAPs and normal snaps, that such similar looking conductions can be seen in other motor axonal neuropathies or anterior horn cell diseases, diffuse polyradiculopathies, myelopathies, end stage diffuse myopathies, and even in certain presynaptic neuromuscular junction disorders. So again, that specific finding does not help us in saying that this is ALS. So during the early aspects of the disease, the CMAPs, like I said previously, CMAPs, the conduction velocities, the F waves and all may be initially normal. Because it is affecting only in the large pool of motor neurons, only certain neurons are getting affected. As and when more and more fibers, the faster conducting axons are getting involved, gradually we might see some mild distal latency prolongations and mild reductions in the conduction velocities, but it will never reach any demyelinating range that we normally see in other kind of neuropathies. So what we always like to look for mimics when we are looking at an NCS of patients with suspected ALS. So we will not see very low conduction velocities or significant temporal dispersion in patients with definite ALS. And it is important to understand, we must tailor our nerve conduction studies based on clinical presentations. For example, a patient who comes with a finger drop or a wrist drop or maybe proximal onset weakness, maybe we should, the routine median ulnar, peroneal, tibial, TA conduction may not reveal the problems, and maybe we need to ask for additional conductions like radial and proximal conductions to understand where the problem is. So certain unique things that we can see in ALS is these kind of split hands, where as you can see in this patient, the thenar muscles are wasted and the FDI, other introsure also wasted, but the hypothenar, the ADQ relatively is spared as compared to the thenar muscles. So such a presentation where though they are from the same myotome, C8T1 myotome supply, or T1 predominantly supplies both thenar and hypothenar, there is this laterality where the lateral aspect of the hand, the APB and the FDI seems to be more affected. That is a phenomenon that sometimes we are able to see in ALS, which is called as a split hand syndrome. Though this is not unique, and we can see these similar kind of things in SMAs, in Kennedy's disease, in post-polio syndromes also, but it is something that it's important to look for. So the various, this is from the recent JNNP article on the various possible hypotheses that they have for this presentation of split hand, where they say that it is the exaggerated cortical representation of the thenar muscles in the cortex and subsequent feed dying forward glutamate mediated excitotoxicity to the anterior horn cell, which causes that selective involvement to the lateral aspect of the hand. There are other abnormalities where there is intrinsic problems. They are saying that even between there is selectivity in the ventral horn cells, and that certain neurons which are more supplying the APB and the FDI get affected more. So that is the dying back degeneration in the dying back axonal regeneration. And in some of them, there are specific neuromuscular junction abnormalities in these neurons. So these are all the various hypotheses that they mentioned on why this split hand phenomena occurs. And the opposite, and similarly, people have just as a correlate of the clinical finding, people have actually looked at this neurophysiological correlators, they've looked at the ratio of the CMAPs of the APB and ADM, and they've looked at what is the sensitivity and specificity of patients against control or against disease controls, and finally, did they all turn out to be ALS later on in life? The whole point in neurophysiology is can you exclude mimics? Can you diagnose ALS early? That is, so at every point in time, that's what we are discussing. So there's something we are looking at these ratios of CMAP of APB versus ADM. So if you have these kind of ratios, that is suggestive. And there's something called a split hand index where you are looking at the product of the APB, FDI, CMAP and against the ADM. This had little more sensitivity and specificity for patients with ALS. Of course, it's important to understand that we have ruled out coexistent entrapment. So additional ulnar or carpal tunnel syndrome and all will definitely change these interpretations. And opposite to that, there's something called as reverse split hand. So here we find that it is the opposite. The APB is relatively spared, and the ADM and the other interossei are predominantly affected. So this you can see in Hirayama's disease, and this is relatively more common. You don't see this in ALS, and you see this more common in Hirayama or sometimes in cervical spondylotic amyotrophies also. So if you get this might help us in thinking it may not be ALS. So again, it depends on where the disease has started and all that. And so these are some of, if you do F waves in early aspects of the disease, we may not see any significant abnormalities. But as the motor unit loss increases, so as we understand, the F waves are a marker of 1 to 5% of the anterior horn cell pool of that particular nerve. So the CMAP has all of the motor axons generated making the CMAP. F wave is only 1 to 5% of it. So as the motor unit, and that is why when you do a normal F wave recording, I'm not sure if you can see it, but the morphology of the F wave changes from each stimulus. So if you do 10 times, you have different kinds of F wave morphology with different anterior horn cell motor unit was being stimulated. But as the motor units reduce in size, sometimes there's only one motor unit that is firing. And so this is another patient that we had who came to our OPD with a bulbar onset ALS and now probably becoming bedbound. Here we are seeing that it is exactly looking similar. It's like one form of F wave which are repeatedly coming. And if you superimpose them, this is a rastered trace, and if you superimpose them, they are exactly superimposed on each other. So if you get these kind of things, it indicates that there is chronicity and that there is reduction in the motor unit flow. So such kind of F waves are called as repeater F waves. Now, a brief note on root stimulation. It's important to understand that we are using it only in very select situations. It's a situation where patients come with very asymmetric, focal, long duration kind of weakness in a patient who has normally ALS. When we look at weakness, we say that we have a myotomal pattern of weakness. But if a patient, when we are looking at the clinical examination findings, has more of a nerve pattern of weakness, and we are considering the possibility that it could be multifocal motor neuropathy with conduction block, and routine nerve conduction studies when we are doing stimulations above elbow, below elbow, Erb's pointer are not able to demonstrate conduction blocks, and we have clinical suspicion is high for of multi-MMN. This is one additional tool that can be done. But it's important to understand that even ALS, as time progresses, will also show some amount of amplitude decrement when you go more proximally. Even in normal people, there is a physiological temporal dispersion that happens when you go keep going proximally. Prabhakar sir was discussing that yesterday in the grand rounds. So even in ALS, people have looked at, they've done root stimulation for the cervical and even for the sacral roots, S1 roots and so. So up to 45% reduction in the amplitude has been described. Very early papers from 1998. There's been significant reduction in the CMAPs, up to 45% has been described in patients with ALS also. That's something that we need to understand. And that sometimes it's very important to know this is a technically very challenging study. If you've done it, you'll learn that it's a very painful study. The amount of shock stimulation is more. It is not very specific. A lot of muscles are getting stimulated when you are doing a root stimulation. And sometimes it may not be, you're looking at one muscle, and that particular muscle, beyond that muscle also can be affected. And there are, of course, complications when you're doing a cervical root stimulation. And there are very limited reference studies to normal population, especially in India. So the interpretation of such studies are also important. We must understand this, that this is not a routine nerve conduction study that we do for patients with ALS. It's in a very specific subset of population. And when additional nerve conduction studies like proximal stimulation is not able to demonstrate any evident conduction block and the clinical suspicion is very high, that is when this may add to as a add-on to such patients. And finally, among the nerve conduction studies, I'd like to add a brief word on motor unit number estimation. So this was proposed earlier in 1960s. This is primarily for research trials where they wanted to look at what was the number of motor units a nerve had at a specific point in time. And they serially looked at that motor unit numbers over time, and they looked at how much it reduced over time. And so if you are starting a medication for ALS, how do you know if it is effective? So one way is to clinically monitor them, and another objective way was this, where you are saying that the rate of decrement or reduction of the motor unit numbers do not reduce over time. So that is why this came into vogue. But this is predominantly used only in research setting. At least I have never done it in the lab. And understanding it, I've understood it's very technically challenging. There's a lot of time that is required in doing it, and a lot of patient cooperation also required. So just a brief note for the PG. So this is normally when we are doing a routine motor nerve conduction study, we are stimulating the nerve supramaximally, and we are putting the surface EMG over the muscle. For example, if it's the median nerve study, you are stimulating the median nerve at the wrist, and you're putting the surface EMG electrodes over the APB. And as a supramaximal stimulation, you get a CMAP. Now, in these kind of studies, motor unit number estimation studies, what we are doing is we are starting very small amplitudes, sub-maximally, very small amplitudes, and we are recording each motor unit action potential, but by surface electrodes. Normally, we only CMAP is done by the surface electrodes. We do not look at normally motor unit action potentials by surface electrodes. We usually use a needle EMG to look at motor unit action potentials. In these patients, in this studies, we use a surface EMG electrode, and we try to understand what is the surface motor unit action potentials. We gradually increase the rate of stimulation, and we produce something called a surface motor unit action potentials. So what we are trying to do is first we will, in this part of the study which I've understood, is that first they do a supramaximal study. For example, if it's the APB, they do a supramaximal study, and you get a CMAP from the APB, which is, say, in this is an example, which is around 8 milli or 7.5 millivolts. I mean 7.5 millivolts or 7,591 microvolts. And then here, if you look at the display gain, this is 2 millivolt, this is 100 microvolt. Here now we are gradually incrementally increasing the milliampere current, and you are getting these small amplitudes, and we take an average of 9 such recordings. So what we do, so each of these are called surface motor unit action potentials, and each of them have a different value. And the total value of all that surface, you take 9 such incremental recordings. We do not reach the CMAP. We only take 9 such incremental recordings. That's an average. And we divide it by or in this case, 6 recordings were done. So the total surface motor unit action potential, the mean action amplitude of each of this was 373. And if you divide that by 6, you get this value of 60. So this is the mean surface motor unit action potential. So if a patient had a CMAP of 7.5 millivolts, and the surface motor unit action potential is 62. So if you divide that, we are estimating the motor unit number as 122. This is a rough estimation of the. Now we will serially follow this patient up over time. So like that, to do for each muscle, each increment, this is a technically very challenging, demanding, and time-consuming study, which in a busy EMG lab like us is not.
How did 122 come?
So for example, if this CMAP was say 100 microvolt, this is 120, this is 140, this is 150, like that.
That is the CMAP divided by 62, is it?
Yeah, so the whole point is we need to get the mean surface motor unit action amplitude. For that, we take an average of 10 recordings. We add all that, mean of that, and divide by the number of recordings. So here 6 times we have done, so divided by 6. And then this is the estimate. So this was a very old study, and
CMAP divided by the 62.
Surface motor unit potential. So, yes. So this is an example. It's just an example. Normally we do 9. So I had gotten this slide from the AOCCN the plenary session which was there. So Dr. Aditya was discussing. This is how they do their motor unit estimation. So this is our lab EMG, I have not done it. I mean, I've seen that it is there in the. It's there. All these things are there in the commercial EMG machines. Our machines are all there, even the old ones. So now what they have done is it is quite impractical to do all these things. So they have automated it. So here instead of doing 9, what they are doing is they are taking up to 500 incremental stimulations, which is automated. Gradually, the machine itself has an algorithm for doing it. So what it means is in normal patients, this increment is very gradual. One motor unit by one motor unit by one motor unit is getting recruited. In ALS patients who have motor unit loss, this increments when the second motor unit is supposed to happen, there may not be any motor unit to recruit. And then suddenly, because of reinnervation, you might have 3 or 4 recruitments happening when you increase the amplitude. So instead of having a very gradual increase in amplitude, you get a very sudden increase in amplitude, almost like a step ladder. Well, a normal person will be like an S-shaped curve. So that will be how a patient with an ALS mune, the graph will look like as compared to a normal mune in a normal patient. Now,
yes, sir. BMI have any role in?
Sorry?
BMI.
I have not looked at that. I'm not sure.
What? No,
if we,
patients with less BMI and high BMI, with the mean weight different. Muscle atrophy, muscle thickness. Atrophy will not change the motor unit. No, so basically to reach to the nerve, you need a higher current as compared to those factors will be both same for
CMAP and for the and it's a ratio, so I think it gives. So that's my that part of the nerve conduction studies. Subsequently to the needle EMG, which is generally the most important aspect of the electrophysiological study in a patient with ALS. So a patient who comes to the EMG lab with a suspicion of ALS, at that point in time, you're doing a cross-sectional extent of the disease when we are needling that patient. So we divide the ALS by myotomes into bulbar, cervical, thoracic, and lumbosacral myotomes. Among the 4, we are looking at what is that at that point in time, what is the cross-sectional extent element burden of the disease by doing an EMG. And it also gives us an idea what is the duration of the disease based on the acute and chronic changes that you see on the EMG. It helps, it is useful on progression and useful when you are following up the patient where initially patient had disease which was restricted to the upper limb. 6 months down the line, now we are getting more extensive changes. So it helps us in serially following up the patient. But it has its pitfalls in the form of it's difficult to certain kind of muscles, like for example, the tongue, the diaphragm, and all those muscles are relatively difficult to needle and interpret. So in such and the pain and the problems that are associated with needle EMG. So those are the problems that we have. So very briefly, this is the anterior horn cell, that motor axon and the muscle fibers it activates and neuromuscular junction. This is one motor unit. So the various waveforms, the generator of the various waveforms that we are interested in ALS are generally the fibrillations and the positive waves that we see when you're doing the spontaneous part of the EMG needling, and also the fasciculation. So the fibrillation, the positive sharp waves are actually coming from the muscle fiber aspect, and the fasciculations are coming from the motor neuron, initially, at least in the initial aspects of the ALS studies. And so that's what we see in the spontaneous discharges that we see when the muscle is at rest. So the recommended EMG guidelines, this is from Shapiro. The recommended guidelines are that we need to needle muscles proximally and distally in the bulbar, cervical, thoracic, and lumbar myotomes. A lot of importance is given to the bulbar and to the thoracic myotome because mimics like cervical myeloradiculopathy, spondylotic myelopathy and all that generally do not cause changes to the thoracic and the bulbar myotomes. So it is important, and also the importance of seeing both the active and acute kind of changes to the nerve and to the chronic changes. Both are important to demonstrate. If you only have chronic neurogenic changes, that is not suggestive of ALS. If you only get active denervations, also it is not suggestive of ALS. It is the mixture of both acute, that is, there is denervation and reinnervation happening, the demonstration of that, though none of this is specific for ALS. You can see or get all these things in different other aspects of the disease. So this is the spectrum of the ALS. So the acute denervations are characterized by the positive sharp waves and the fibrillation. The chronic changes are the changes in the motor unit action potential. So as you can see, this is the normal motor unit action potential. Over time, with the denervation and the subsequent reinnervation, the motor unit becomes larger. The amplitude, the duration of the motor unit increases. The phases increases, becomes more polyphasic. So these are the changes that indicate that this is chronic, and recruitment patterns which are reduced, and fasciculations also which we see. I'll just take a minute to discuss this. So this is normally what happens in a normal motor neuron. This is from, again, I've taken it from Shapiro. So in a partial once there is a denervation that happens partially to a muscle, there is reinnervation or collateral sprouting that happens from the adjacent motor units. And because these motor units, these collateral sprouts have been developed newly, they do not conduct electricity as fast as the main axon. And so it takes time for the electrical current and cause a motor unit action potential in this motor unit, and therefore it takes a longer time. So that is why you get these trailing potentials, which are called as satellite potentials. So these, if you see, are an indication that there is a partial denervation and a reinnervation that is happening in these patients. Similarly, if you look at this as these two cartoons, so as the disease becomes more and more chronic, and there is significant, and the motor unit number reduces, and finally it becomes nearly 1 or 2 motor units, and that single motor unit is reinnervated all of these other adjacent ones. These small satellite potentials will eventually get added on, and the morphology of the motor unit changes from a triphasic to polyphasic, large amplitude, long duration kind of ones. Now, this is what happens if there is reinnervation. Now, sometimes in certain very rapidly progressive disease or end stage, when there is no reinnervation happening, you get very low amplitude potentials, and sometimes when you get such very low amplitude potentials, it can be mistaken for muscle myopathic kind of motor unit action potentials also. So in such cases, it is the recruitment of the pattern which differentiates the neurogenic from the myopathic interference. So this is the recruitment pattern that we see when you are activating. Sorry.
It's important to differentiate between partial denervation and early denervation.
No, I'm just trying to show these are the morphology that we.
Satellite potentials are normally,
Yes, sir. So
smaller needle length, you'll recording from 2 motor units, with 2 muscle fibers that are from the same motor unit.
Yes, sir.
The normal thing.
Yes, sir. But I forgot the number is more than 10%. If you see, there is. So we're not doing quantitative this thing and all. I'm just talking about the morphology. There is, of course.
So the number of satellite potentials is much more.
Then yeah, will be more. Yes.
Is it important in this, like in a traumatic injury, we often try to differentiate whether this is a partial denervation or early denervation that is causing a loosening up? Is it important here or it's not?
So I think that we are looking at this and
question is there motor neuron disease and how does it matter? Unless I doing research on disease modifying.
And also a brief note on the recruitment pattern. So this is the normal recruitment pattern, maximal firing that we see when you're recruiting muscles, when you're recruiting a action. And this is what you see when it's a neurogenic kind of recruitment, is picket fence like, there's reduced recruitment that we see. And in patients where spasticity is the most dominant form, where element may not be very dominant, we see this reduced thing, which is because of the reduced activation, which is because of the pyramidal. Even patients who are poorly cooperative, or if there is pain and if they don't activate also, we might get this. So if in a patient who has spasticity, we might get such a reduced recruitment, which is maybe because of the spasticity also. It's a unique condition in ALS where patient has both spasticity and LMN and UMN dysfunction, though one might see both. And finally, like I just discussed previously, where sometimes when you have partial denervation and you get these kind of satellite potentials. So what it means basically is that there are these are all new neuromuscular junctions which are forming. And so every action potential which is generated and which is carried out through the whole motor unit takes some time. So sometimes they fire normally, sometimes they don't fire at all, sometimes they fire reduced. So that will also be seen when you do recruitment for such muscles, where the amplitude of the motor units keep changing. So these are what we call as unstable motor unit action potentials, or in them. And
I think very important. Like the in spasticity firing rate reduces motor unit, and is that relevant here, or because there's element also it becomes difficult to
that's what. So that is that 5:1 ratio. So for 5 hertz we are expecting 1 motor unit. For 10 hertz we are expecting 2 motor units to see. So in spasticity, in spite, if we are very sure that the patient is fully contracting, we are able to clinically assess that. And in spite of that, if patient is only able to activate, we are only able to see this much, then it is possibly that this is reduced activation and not reduced recruitment. While in this, when the patient is fully activating, and this is the kind of that is a number for the frequency number of motor units. So this is at 30 hertz, only 1 motor unit is seen. I mean, I forgot to put that legend. So this is definitely a reduced recruitment that is seen in this. And similarly, the changes in the motor unit action potential also. So this is a normal motor unit action potential that we see. So normally it's between 200 microvolt to 2 millivolt. You get very large kind of motor unit action potentials in chronic diseases, and so what we call as giants. One brief note on diaphragmatic EMG. It is dominantly important only when normally we are correlating the diaphragmatic disease with the phrenic CMAP that we are doing clinical presentation also. But sometimes when the disease starts as a respiratory onset disease and relatively less limb weakness or bulbar weakness, sometimes diaphragmatic needling may help, but this is only relevant in less than 3% of the cases. It's a very rare thing. And it can also be useful in certain patients who can, normally otherwise we correlate the bulbar and the diaphragmatic function with the spirometry also. So in patients who have significant bulbar disease who are not able to oppose their lips, or in patients with frontotemporal dementia with ALS who do not understand how to do it, maybe doing these kind of things will additionally help. But it is definitely technically challenging. Putting a needle into the diaphragm has its own risks and difficulty in interpreting the findings also, because this muscle is not at rest. The interpretation of the spontaneous discharge is also difficult. There's been studies where instead of doing diaphragmatic needling, people have tried to, because the cervical medial aspect of the cervical anterior horn cells is almost the same, embryologically they come the same myotome as the diaphragm. So instead of doing the diaphragmatic needling, they have correlated that with doing cervical paraspinal and cervicothoracic paraspinal needling. And if you get extensive cervicothoracic paraspinal needling to spontaneous changes, that generally correlates with denervation changes in the diaphragm also.
Diaphragmatic EMG is not so technically. You commonly do it also.
Yes, sir.
You can either do it ultrasound guided if you're worried about injury. So you can just go directly subcostally if you go. That's where the extension of the diaphragm, that's where most of the muscle is also.
Yes.
So once you go inside, you'll know that during inspiration, the diaphragm is moving, it will fire, and between the breaths, the patient is relaxing, you will get nice positive something. It's quite easy to do.
So this is the routine kind of things that we are doing, apart from certain additional points. With the routine kind of things that we are doing for in patients who come to the lab. Now, like I said specifically, there are certain deeper areas of the muscle which is difficult to access with the needle, or certain muscles which is difficult to relax, like the tongue. People have started using ultrasound as a correlate for picking up fasciculations in the tongue. I'm not going to discuss because of lack of time. And there is one group also which discusses the utility of using H reflexes in apart from the soleus H reflexes in other muscles, and to demonstrate that if you are able to demonstrate H reflexes which are not normally present in people, not in normal population, but present in them, and if you're able to demonstrate that in the you can say that it's a hyperreflexic for that arc. UMN dysfunction can also be demonstrated by TMS studies. Again, I will not be discussing that. So this is one discussion that was present from this Professor David Berg from Australia, where he had a patient who came with progressive LMN kind of weakness in the lower limbs. Clinically did not have any UMN findings. And he is trying to show that this patient has subclinical upper motor neuron dysfunction also. So he has done in normal people, in patients with ALS and other conditions, H reflexes in TA. Apart from the soleus, he does tibialis anterior, ECR, and APB. According to him, it is not normally, you will not get an H reflex at rest in these muscles. But if you are able to demonstrate such H reflexes, which you can see here, and then the subsequent M wave in the right and left TA, So if you are able to demonstrate that there is an edge reflex in these muscles, this could be taken as a correlate of a upper motor neuron dysfunction. This is only one group which does it, and it's technically a little difficult to do also. They've given extensive references for this, so it's something that we can look at. And just there's some new updates in the diagnostic criteria also. So previously the diagnostic criteria for ALS was the LS Coriel, the revised LS Coriel, and the Avaji criteria, which in the LS Coriel, the revised LS Coriel, it was the clinical demonstration of findings of upper and lower motor dysfunction in at least 3 to say definitive ALS. While when the Avaji criteria came in 2006, they started giving that apart from clinical, even EMG findings can also replace the LMN clinical signs. That if you get EMG on clinical if you even LMN on EMG also is equal to a clinical examination of LMN. And that they added the addition of fasciculation also. So the whole point again in all these criteria, again as research criteria, was that they wanted to recruit patients to trials, and say they wanted to start them early into the trials. So by all these criteria, this improved the sensitivity to 57%, but the specificity was kept very high, because we didn't want any mimics to be enrolled into the trials. So more and more people were getting and they were unhappy with the sensitivity, and they wanted to recruit patients earlier into clinical trials. And so for most of the experienced clinicians who see patients with ALS, especially for example bulbar onset ALS, they're reasonably sure that this patient is going to progress like an ALS patient. So for them, possible, probable, or definite was just like how the disease progressed for them, just an extent, and not that for them diagnostically they were very sure, even with the first visit, OPD visit also. And also for patients and for clinicians also, there's in all these criteria there's definite, probable, possible. So inter-rater correlation was apparently not very good when in large ALS trials. So they wanted a criteria where patient will say ALS or no, not ALS. They wanted to simplify it much more. And certain variant types of ALS like primary lateral sclerosis could not be classified beyond possible ALS in the current ones. And so in 2000, in late 2019, early 2020, they proposed this new Gold Coast criteria from Australia, where according to them, ALS is a progressive disease, and which is demonstrable on repeated by history or repeated clinical assessment with prior normal motor development. And they simplified into presence of just UMN and low LMN dysfunction in only one body region, or LMN in two body regions. And the most importantly, investigation excluding other disease processes. Made it very simple so that more patients with early onset ALS are recruited into clinical trials. So this was what was proposed in 2020, and subsequently validation of this criteria was done, where they looked at prospectively 506 patients from two large ALS clinics in Australia, where they looked at the sensitivity and specificity of patients of the different criteria, the revised LS Coriel, Davaji, and the Gold Coast criteria. So if you look at, for me, the most interesting thing was that though more amount of motor neuron disease were earlier picked up, there were equally large amounts of mimics which are also initially called as ALS. So the reference standard here is, if you have called probable ALS, reference standard is subsequent 6 months later clinical electrophysiological progression and exclusion of other corrects. So that was if they progressed like ALS, subsequently they were changed from mimic to ALS or ALS to mimic. So the old criteria had very good specificity, that is they didn't, mimic disorders were not recruited, while the newer criteria we were able to classify ALS earlier, but it is important that exclusion of the mimics is excluded. So these were in that cohort of 506 patients. This were the mimics that were initially included into the ALS, and subsequently after 6 months were then revised into the mimic disorders. So CIDPs, acquired neuromyotonia, myopathies, Kennedy disease. So these were the ones which were the mimics, which was initially considered as ALS in the initial registry. And then they looked at the specificity and sensitivity of the criteria for this in this prospective study, and they found very good sensitivity and specificity in all of them, irrespective of whether the onset of the disease was bulbar or spinal onset, and irrespective of the severity of the ALS, and irrespective of the disease duration also. So in all of these things, they found that this criteria was helpful in earlier recruitment of patients with ALS. These were some of, so what they have done is in the possible criteria of
The sensitivity
has gone down, yes sir. So which is 99% or 100% initially is mildly reduced to 88%. But they are saying that in experienced clinician hands, that pickup is pretty good. So that for a normal neurologist, maybe these things need to be seen, pragmatic real world data. So these were the observations that they have started from. Initially in the criteria, it is normally the probable and the definitive ALS, which was earlier recruited into trials. Now from possible ALS itself, we are able to hike them up into ALS. And now it's just yes or no, it's either ALS or not ALS. And that patients with this progressive muscular atrophy variant is, you are able to diagnose them as ALS, while PLS has been removed from this criteria because they say that the way they progress and their survival and all is different, so that needs to be looked at separately. The EMG definitions of the fasciculation, denervation, chronic and acute remain the same as compared to the Awaji-Shima criteria. So why this is important is because apart from the diagnostic criteria, there is a staging, a functional staging on how the ALS progresses over time. So first is the symptom onset and diagnosis when the first clinical contact happens with the clinician, and then subsequent progression. So when we looked at them over time, the Gold Coast criteria was able to pick up more amount of patients in the earlier aspect of disease. So stage 1, stage 2, stage 3, roughly they say that 30% of the neurons are affected in the pre-diagnostic phase. Stage 2, when they reach the clinician first point of contact, 40% are reduced. By stage 3, stage 4, 80% of the motor neurons are getting damaged. So with the old criteria, we were diagnosing them later here. While with the earlier criteria, we are diagnosing them a little more earlier. So I'd like to talk about a few interesting other mimics that we need to consider before we say ALS. So this was a paper in Practical Neurology by Professor Matthew Kiernan, where a lot of neuromuscular referrals were from clinicians, especially neurology consultants or trainees, who came with fasciculations to him, around 20 patients over a period of 9 years, which he followed them up subsequently for 10 years. So in them, he noticed this was that most of them had fasciculations which worsened with stress, caffeine, or exercise. He describes one of the French physician called Dr. Laurent, who initially started having this in his busy OPD, started noticing fasciculations, and then he became insomniac. Then he thought he was going to die because of motor neuron disease. And then subsequently, with reassurance and EMG, he was able to make him understand that. So these were his inferences when he looked at these 20 patients, out of which 17 were this syndrome, that is benign fasciculations, while 2 of them had a neuropathy, sensory, like a CIDP, and 1 of them progressed to ALS. That is when he came initially with just fascics, subsequently follow-up showed. So even though initially all of these will be normal, it's important to follow them up also later clinically and EMG and conduction wise. So 1 or 2 cases also I thought we will discuss. So this is a patient who was recently admitted in A block. We've been following up from 2016. As a 60-year-old man who had come following after dinner party in December 2015, he noticed that he had progressive mild difficulty in lifting up his ring finger when he was trying to hold the cutlery while eating food. Fork, the knife he could not grip properly. And subsequently, over a period of 6 months, sequentially he started noticing weakness of the other. No, sir, over 6 months. He noticed it one day, but then it progressed. He noticed it during a dinner. That is when he noticed it. But then subsequently, gradually progressed into other fingers. Initial at that time, all we found was that he had mild reduction in his radial nerve conduction. He had a carpal tunnel syndrome also. I'm not sure if it's visible, but there was mild motor axonopathy in this. But clinical examination showed that he had weakness of his wrist and finger extensors, weakness of his interossei and of his APB and flexor pollicis longus. So at that point in time, the question was whether this was ALS versus an MMNCB. And no human science clinically, no sensory also.
Other
were normal. So this was the needling that was done initially, which showed active denervation changes and some chronic on the left hand sir. Yes sir.
What cutlery is using in the left hand?
Knife.
Knife.
So the EMG initially showed some denervation in the extensor digitorum communis. The EDC, the ECU, FDI, all of them showed. So the question was whether he had an MMNCB or he had come 6 months into us. December 2015 was when he started noticing this. June 2016 is when he had come to us at that time. And subsequently, Matthew sir had done nerve conduction studies, and he was able to demonstrate that even just from that there was a progressive reduction in the CMAP in the proximal stimulations. So this is the wrist, this is the elbow, this is the axilla, this is the Erb's point, and this is the stimulation from the C8 root when they were looking from the abductor pollicis brevis, and there is a reduction. So this is, I mean, from 8.3 to 5.7 to 0.6. So this is at 1 millivolt, and subsequently, sir has then looked at it at 500 microvolt. So it's the same from the same C8 root. Sorry. He was also, so this is one nerve. He was able to demonstrate such changes in the other nerves also in ADQ and APB. So yes, sir. So first, his ganglioside antibodies were negative. CSF was.
What's the last one in the?
So this is the radial.
The first. No, the last one was almost normal.
No, yes, sir. So this is at 1 millivolt. I'm sorry, I couldn't. This thing. This is at 500 microvolt. He has changed the display setting. That's all. It's the same. Yeah, that's the gain is different. 1 millivolt is 500. So it's the same low, low amplitude motor. So because on the EDC the distal CMAPs are very low, we cannot demonstrate any conduction blocks. So this patient subsequently received IVIG in cyclophosphamide, and we have been following up for the past 5 years. There was improvement in his clinical, in his weakness. This is another patient that.
Even diagnosed with MMNC.
Yes, sir. But ganglioside antibody and all, but clinically, electrophysiologically, and response to therapy was there, and 5 years we have followed him up. Yes, sir. Yes, sir.
Monomelic amyotrophic.
Yes, sir. 60.
And it was more radial than.
Yes, sir. And imaging, no entrapment was there. Ultrasound.
Clinically, it was like a radial normal, like a
radial dominant, but there was weakness in the yes also. So he has element sign only in one region, sir. I mean, yeah, in 2 regions. So this is element only in 1 region. So we will not still call it ALS. And if it is only in 1 region, then you must demonstrate LMN and UMN in the same region. So if your disease is so focal, let's say from foot drop, and you want to say that is ALS, then you must demonstrate that there is UMN in the same region.
But T1 comes as like you say that ABB is T1.
Yeah.
But we don't count it as thoracic.
No, I've not thought about it like that. I've not thought about it like that.
But then, we always all this
yeah, I've not thought about it like that. It's a good point. I'll read up. Can we move on to the next? So this is another patient to come to neuromuscular OPD, seen Ajit sir actually. It's a 68-year-old man from Bangladesh who had presented to us with 8-year illness of dysarthria, dysphagia, and mild difficulty in getting up from squatting position. So he was diagnosed as bulbar onset MND 8 years back, and he was been on Riluzole. So he had come for a second opinion here. He had not clinically progressed. He was still able to swallow food. He's still able to walk. So that was one of the odd points that we considered. Clinical examination showed that he had mild wasting of the temporalis, and he had wasting and fasciculations of the tongue. And here, I don't have a video of him walking, but he had mild difficulty in getting up from squatting position also. His reflexes were all dropped, no UMN signs.
No wasting, yes.
No wasting, no cerebellar signs. So nerve conduction studies again show that there is reduction in the motor CMAPs. Actually, we can actually see that the right median is more involved than the right ulnar, or the left median is more involved than the left ulnar. And his snaps are also reduced. So initially, it was considered he had a sensory motor axonal polyneuropathy, but why bulbar onset dysfunction was the question. EMG showed only chronic changes. There was hardly any active denervation that we were able to demonstrate in them. So subsequently, when we re-examined him, we also picked up that he had a gynecomastia. So a 68-year-old gentleman, progressive bulbar weakness, gynecomastia, low snaps, reduced reflexes. We thought of the possibility of Kennedy's disease. Subsequently, genetic testing confirmed that diagnosis. So, and then lastly, I like to talk about this lady who had come to our ICU in June 2020 during the COVID period. 41-year-old lady who had come to us with a 1.5-year history of mild difficulty in getting up from squatting position, some neck pain, and occasionally used to droop her head while speaking. And then rapidly, this was there for 1.5 years, mild worsening of those weakness and upper limb weakness for 1 month before presenting to us. And then over 1 week, suddenly becoming orthopnic and going to the government hospital and getting intubated. So the working diagnosis there was a acute, chronic neuropathy, and she was given pulse steroids there, and subsequently she went into sepsis, septic shock, and got intubated and had been transferred here for further evaluation. So when she had come to us, her ABG at admission was, she had showed a pH of 7.07, PCO2 was 100, lactates are also high. So she had sepsis, she required inotropes and all that. So the question, element dominant syndrome, the clinical impression, it was a proximal predominant weakness, proximal more than distal weakness with neck drop, and was respiratory wound and bulbar also. Clinically had bifacial weakness also. So the question was clinically pure motor. Sorry, sir? No, historically there was no diurnal fluctuation, no bulbar symptoms previously. The clinical localization was muscle, NMJ, or anterior horn cell. There was no UMN signs on examination, no sensory deficit previously. So the nerve conduction study showed diffusely reduced CMAPs in the upper limb. She was edematous also, and her snaps are also reduced. So initially when she was intubated, she was fully sedated and ventilated. Her initially needle that was done showed extensive denervation. We could not check her interference pattern or motor unit because she was sedated, and we could not do any motor unit action potential. So at this point in time, there was a question whether she had ALS and whether we should continue treatment for her. But at 41 years, 1.5-year history, proximal more than distal weakness and all, muscle was still considered a possibility. CPK at admission, sorry, I forgot, was 1,400. So then subsequently, when she started improving a week later, we repeated a needling again. So here we got a little more, we were able to recruit more. Some of the motor amplitudes were little on the higher side. So at this point also, there was a discussion whether this patient had a motor system disease and all, but subsequently, again, when taking multiple times history, the history was more for a myopathy. And so subsequent needling again revealed that disease was more towards a myopathic kind of process. And finally, the muscle myositis profile came as strongly positive for SRP. She improved with subsequently we were able to slowly wean her off from the ventilator over 2 weeks. And then subsequently she was given steroids and low dose rituximab. Then she was finally transferred to SMH. So diagnostic difficulties that we had in patients who come with acute neuromuscular respiratory failure in diagnosing pure element dominant syndromes are these are the challenges that we face, especially in the critical care setting. So that is all. Sorry.
Muscular EMG. Muscle stimulation EMG.
Again, I don't know in critical care setting how much we'll be able to interpret.
Discussing that.
Yeah.
Wants to start doing
it. Normally it is.
In this patient.
Yeah.
You had a muscle EMG.
Yeah. So that's.
Yeah. Recording over surface and
direct muscle stimulation.
And stimulate the muscle itself. And you compare the nerve with the muscle. If it is a muscle cause, then we show.
So it's been initially well described in the critical illness myopathy and critical illness neuropathy where they have looked at it. I'm not sure. I'll read up. So that's all. I like to finish with this, that the ability of a neurologist is it's most hard when we say that patient has motor neuron disease and we serially follow them up over time. I have a relative who has motor neuron disease diagnosed here under Vivek's follow-up, and I'm following her up. She was a teacher. She had a bulbar onset disease, and now she's become bedbound after 2 years. So it's important discussion, symptomatic management, all which I have not covered in this lecture. It's important to that holistic treatment is important for them. Thank you.